Hi, my name is Mithil Patel. I'm a consultant in restorative dentistry at the Royal London Hospital. On the 18th of May 2017, my colleague Dr. Shakil Shaddad and I are going to run a Tubules live event talking about implants in the aesthetic zone. It's going to be an interactive session where we're going to showcase some interesting cases which will be beamed from London to the rest of the world. And we hope that you will join us on the 18th of May 2017.
Now, let's look at the cases that will feature in this live stream. The first case is about an upper left central incisor, a 61-year-old male patient who was referred from the general dental practitioner with regard to the failing upper left central incisor. The patient complaint was about a recurrent infection and recession related to this upper left central incisor and discoloration around the upper right central incisor. The history of the presenting complaint was that the upper left central incisor was crowned more than 20 years ago and it had apical surgery with an amalgam retrograde filling about 10 years ago. The upper right central incisor had root canal treatment completed more than 20 years ago. Have a look at the tooth. Medically, the patient was fit and well other than some hypertension. He was a regular attender, a non-smoker, and he had a medium smile line. But if we look at the tooth and the tissues around, the soft tissues showed a 7mm gingival recession around the mid-buccal of this upper left central incisor, and the recession extended to the apex of the tooth. Periodontally otherwise, he had good oral hygiene, with BPE codes of 2 and 1 in all sextants. The upper left central incisor was tender to percussion and it was also grade 2 mobile. The upper right central incisor was discolored as the patient had presented with a complaint. Also, the upper left lateral incisor was rotated and there was mesial and labial recession. Let's have a look at the radiograph of this tooth. There was a post crown with open margins. The tooth was root filled with an amalgam retrograde filling, and it was a short root. The upper right central incisor had a single cone root filling and an apical radiolucency. What would you do in such a case? What is the diagnosis? What is the prognosis for the upper left central incisor? And what is the prognosis for the upper right one as well? What are the treatment options available? If the tooth was to be extracted, what are the likely consequences? Is implant an option in such a case? What sort of aesthetic risk factors are pertinent in determining the outcome in this case? How would you manage the hard and soft tissue deficiency? And what are your treatment options for the upper right central incisor? Dr. Shakil Shaddad and Dr. Mithil Patel will be discussing this case and also explaining and showing you how they managed this case with Tubules Live on the 18th of May 2017. But wait, there is a second case we will be looking at as well. Let's look at this case and its history. This was a female patient, 43 years old, also referred from the general dental practitioner with regard to a failing upper right central incisor. The patient's complaint was persistent pain and infection related to the upper right central incisor. The patient has been informed that the upper right central incisor cannot be saved and needs extraction. This is why the patient got concerned and she wanted to know what her options are. This led to a referral. The patient gives a history that the tooth was traumatized at the age of 13 years. She fell and developed a complicated crown fracture. Root canal treatment was completed and the fractured portion of the tooth was restored with a porcelain veneer. No problems were noted until 2013 when the patient started to develop a throbbing pain with recurrent buccal and palatal swellings around this tooth. The general dental practitioner advised extraction and for the moment prescribed antibiotics to manage the acute symptoms while he referred her on. In terms of looking at the tooth, she had a high smile line. In terms of the soft tissues, there was racial pigmentation of the gingivae that was noted. Buccal and palatal sinuses were noted on the upper right central incisor, and buccal and palatal tenderness was noted as well. Her oral hygiene was well maintained, with some interproximal deposits of plaque posteriorly, with a BP code 2 in all quadrants. The dentition was largely unrestored, but she had a midline diastema present. The upper right one was tender to percussion, had grade 1 mobility, and the upper anterior teeth were triangular. Let's have a look at the patient's smile line and what the tooth showed. Let's have a slightly closer look at the tooth with the lips retracted. Let's have a look at the tooth in question. Let's have a look at the radiograph. If this case presented to you, what would be your diagnosis? What is the prognosis for the upper right central incisor, and what are the treatment options available? If the tooth was to be extracted, what are the likely consequences? Is implant an option in this case, or would you aim to save this tooth? What aesthetic risk factors are pertinent in determining the outcome in this case? What are the treatment options for the upper right central incisor? Have a bit of a thought here. In this case, we'll move a step further. The tooth was extracted, and this is the post-extraction radiograph. How would you manage this? If you look at all the options, we've discussed the diagnosis, the prognosis, and the treatment options. We have said if the tooth is extracted, what are the likely consequences? Having seen the post-extraction radiograph, let's look at it again. What replacement options are available in this case? Is implant an option in this case? Would you consider ridge preservation? Would you consider an immediate implant placement? If you were to carry out some form of ridge preservation procedure, what would your approach be? Remember, this is a case in the aesthetic zone, and getting a good aesthetic outcome is critical. Do you think this case requires a block bone graft and a stage approach? Dr. Shakil Shaddad and Dr. Mitul Patel will be presenting both these cases on the 18th of May 2017 from 18:30 hours GMT on Tubules Live, which will be beaming from London to the rest of the world. We hope to see you.
And we hope that you will join us on the 18th of May 2017.